Welcome to the long-promised and much-expanded second edition of the IHPC Advocacy course. This is a freely available introduction to what will be an 8-module course beginning in October. So in this presentation, I'm going to address the background of the course, some key definitions, the ethos and principles of IHPC advocacy, the why, how, what, where, and when of our advocacy, a course outline for what's coming and the modality of the course, some selected readings that we've used for this presentation, and acknowledgements. IHPC is a global nonprofit membership organization headquartered in Houston, Texas, USA. Our vision is a world free from health-related suffering. Our mission is to serve as a global platform to inspire, inform, and empower individuals, governments, and organizations to increase access to and optimize the practice of palliative care. And you can find those in our strategic plan and our annual reports, which are on our website, hospicecare.com. We are also a non-governmental organization in consultative status with the UN Economic and Social Council, and we're a non-state actor in official relations with the World Health Organization. That means that we get to participate in the meetings of the UN entities when we are invited, which is quite often. So the first question I'm going to address is why advocate for palliative care rather than just provide services when we're so adamant that there's such a great need for services? Well, that's why, because one reason is to share the vision of a world free from health-related suffering in the public square. In other words, we do, the benefits of palliative care for patients and families and communities, but most people don't, and most policymakers don't. So in order to implement the global commitments about integrating palliative care into primary health care and universal health coverage, we have to advocate and share that vision. We also have to generate the necessary political will to drive policy development and funding so it's available. We have to increase palliative care literacy at the policy and population levels to secure universal availability. And that just means to make sure people understand what palliative care is, because as I said a minute ago, most people don't understand what it is and don't understand the benefits, and therefore there's no political will to implement it. We also have to overcome the opioid phobia that often prohibits access to medicines in many countries, with evidence and stories to ensure adequate global availability of essential medicines. So it's not just available to the lucky few in a certain catchment area or in a particular country which doesn't have such unduly restrictive regulations. So we overcome opioid phobia by speaking about palliative care in the public square and sharing stories of patients who have used opioids to their great benefit and often have recovered from some of their conditions. So just introducing myself, I'm Catherine Pettis. I'm the Senior IHPC Advocacy Director. I have 7 years on the job with IHPC. I became an advocate because I was so impressed by the generosity, the solidarity, and the charity of all the global practitioners I met about 10 years ago at a leadership conference of global palliative care providers in San Diego. And I just thought I would try and put my policy awareness and knowledge and experience at their service and at the service of the global palliative care community. So as part of my job, I promote palliative care at the meetings of UN entities. I coordinate the activities of the advocacy focal points in various countries, and I represent IHPC at global, regional, and national palliative care conferences and policy events. And my bio is available on the website, as you see here. So why are we offering this course, and why now? And there's an enormous unmet global palliative care need that demands palliative care policy or public health policy that includes palliative care policy, and that in itself entails advocacy. So you have the enormous global demand, and in order to share the information about that and to meet the demand, we have to do advocacy and we have to learn about it, because very few medical or nursing or social work or spiritual care schools teach advocacy. Perhaps none of them do. So there's an increasing worldwide demand for advocacy skills for palliative care because people want to spread the word. Also because it's an evolutionary process. We do have many international gains that I will share with you later, and we have to anchor those at the regional, national, and community service delivery levels. And in order to do that, we have to advocate and learn the skills. One part of our strategic plan, which, as I said, is available on the website, is an advocacy pillar, and we are charged by our board and our membership with creating a global social movement for palliative care, which again entails advocacy. So some key definitions and concepts. Palliative care is obviously the first one, which many people don't understand. And this is the definition that was curated by the International Association of Hospice and Palliative Care in 2018 by a group of almost 500 individuals, practitioners, representatives of associations from all over the world in a very structured Delphi process, a consensus process that came up with this definition as the active, holistic care of individuals across all ages with serious health-related suffering due to severe illness, and especially of those near the end of life. It aims to improve the quality of life of patients, their families, and their caregivers. And I suggest you go to the definition on our webpage because there are several ancillary pieces of it that need to also be read. It follows the model of the WHO definition of palliative care, which itself is about 20 years old, and which many practitioners around the world felt needed to be updated to represent what we actually do. So an official definition of health advocacy, there are many, but this is one that works, is the process of gaining political commitment for a particular goal or program. And this is identified by some as a critical population health strategy. So in this case, we identify the need to integrate palliative care as a critical population health strategy. And advocacy itself is the process of presenting evidence-based information. It's an educative process, as opposed to lobbying, which is when people try to influence a politician or a party to change how that person or that party votes or formulates legislation. IHPC is not allowed to lobby under American law, and remember, we're an American nonprofit, but we are allowed to advocate at the international level and at the national level if we're invited by the government to do so. So we're allowed to advocate, but not to lobby. That's not to say that the national associations cannot lobby. They certainly can promote a particular piece of legislation, such as a palliative care policy or act, and influence their representatives to vote on that. We cannot do that. Some key systems, definitions, and concepts. Governance is a word I use quite a lot through this lecture, so I want you to understand what it means. It's the act or process of governing, according to Merriam-Webster, and it varies in every context. So that's different from government, which is usually refers to the national government organization. This can apply to a health system. It can apply to the international system. It can apply to the regional systems. It's governance. And then multilateralism is the United Nations system of collective debate and decision-making. It's global, it's consensus-based, as opposed to being unilateral, which is one country, or bilateral, which is just two who are calling the shots. Multilateralism produces authoritative agreed language, such as is expressed in resolutions, for instance, like the World Health Assembly resolutions. And advocates can leverage that agreed language in the resolutions with their governments and institutions, because those are commitments their governments have made. They've struggled over the language, they've agreed through a consensus process in the multilateral governance arena, and at the national and local level, we can use that language. Some key systems concepts are civil society. We are known as the third sector. Third as opposed to the first and second, which are government and industry, or the private sector. And just some examples of civil society organizations, global ones, are ourselves, the Worldwide Hospice Palliative Care Alliance, and the International Children's Palliative Care Network. We're the three global palliative care civil society organizations, and then there are the regional and national associations. Those are the palliative care civil society, but there are plenty of other public health. It's key to remember that we have the right to advocate for palliative care in the UN system. This isn't just because we want to do it. The UN High Commissioner for Human Rights has stipulated that civil society organizations have a right to advocate. This is in General Comment 25, which is the International Covenant on Civil and Political Rights comment. And it says that citizens take part in the conduct of public affairs by exerting influence through public debate and dialogue with their representatives or through their capacity to organize themselves. So that gives us the right to participate in governance, which is supported by ensuring freedom of expression, assembly, and association. And this is what our advocacy seeks to do, to get a seat at the table. Because if we don't have a seat at the table, we're probably on the menu, which means that we're going to get sidelined or just gobbled up in whatever political priorities will push us away at the time. Organizations doing palliative care advocacy must have a legitimate institutional profile. Advocacy is always an institution-to-institution process. It's never what individuals do. That could be influence. There's no doubt about that influence can come from individuals. But advocacy is done, of course, by individual people, but through an organization to an organization, which in our case are the UN entities. In your case, it may be your national government or your national health system or your institution, which you're trying to persuade to include palliative care in the curriculum. But you still need a legitimate institutional profile. It's helpful to have an advocacy focal point, which is one person in your organization who is dedicated, at least to some extent, in learning about what the issues are for advocacy. Someone who has the capacity to absorb and act on new information, because this is not taught in medical schools or nursing schools or social work schools. This is new information outside the clinical comfort zone. It's important to have the desire to build productive relationships with decision makers and with the media, people you may never have met before. Basically, you need to be able to be willing to make new friends when you're doing advocacy. And of course, these organizations need visionary leadership and volunteers, because effective advocacy requires mentoring. We're all learning from one another. None of us were born knowing how to do this. We require mentoring and a joined-up approach, not one person doing one thing here and one person doing another there, and the left hand knowing what the right hand's doing. We're really trying to coordinate this so that we have a joined-up approach and we're an effective social movement. We advocate at all levels of governance. This is what I was speaking about before: the local level, the national level, the regional level, and the global level. We support our members and our colleagues at all those levels to do advocacy. At the global level, we advocate, IHPC does, with the UN entities, because the UN has said specifically that the United Nations recognizes the importance of partnering with civil society, because doing so advances its ideals, one of which is peace and security. And we know how palliative care can bring peace and security to families, caregivers, and communities. And it helps support its work. So we're helping support the work of the United Nations through our advocacy and through our work. Advocacy is presenting information through an interdisciplinary team of advocates that mirrors clinical practice. Just like clinical practice in many countries, we're volunteer dependent. In some countries, you're not volunteer dependent, but in the US, and I know in Kerala in India, they use a lot of volunteers. And one of the reasons that advocacy is so volunteer dependent is because there are very rarely budgets for advocacy. Fortunately, there's a budget for my job, but there are very few other budgets for people doing advocacy at the national level. And that's something we're working on, but it's not happening immediately. So in that sense, advocacy mirrors and reflects clinical practice. It's collaborative, it's not confrontational, it's a collective learning process. And I see it very much because, as I said, I was a hospice volunteer for a long time, as a continued adjustment of goals of care conversations. But our goals of care are care for the common good, whether it's the national common good, the community good, or the global common good that comes from introducing palliative care as a primary healthcare good. And that's what the World Health Organization has designated palliative care as a global public good. And so we reflect that in our advocacy at the governance level. The ethos of palliative care advocacy likewise mirrors the ethics of clinical practice, because our primary ethical commitment is to non-abandonment. So the family and the patient and the palliative care team, the interdisciplinary team, are always at the center of our concern. Not the good of our organization at the center of our concern. It's certainly in there, but the center of our concern is the well-being of our patients and families, just as it is for the interdisciplinary team. And then inclusivity and proximity are very important because it includes the voices of all impacted populations in our advocacy. Proximity is the requirement that the people who do advocacy either be people with palliative care needs, or be providers, be family members or family caregivers, or be persons who have been involved in palliative care for years through proximity, for instance, myself as a volunteer. And when I go to other countries, I go out with the home care teams and see how they're working with their patients and families in the field. The other important ethic that we try and implement in our advocacy is mutual and shared responsibility, which is that ethic of solidarity and collaboration, which is non-rivalry. It's not saying that we're rivals of any other organizations. We are in solidarity with you. We are collaborating with you for the benefit of patients and families around the world. This is an all-hands-on-deck effort, and any kinds of rivalries or competition has no place in it. So the global disabilities movement coined this phrase, "nothing about us without us," when they were campaigning for a Convention on the Rights of Persons with Disabilities, and we apply that to our advocacy also, that nothing about palliative care advocacy without the impacted populations participating. So these are the whys, the whats, the whens, the wheres, and the hows of IHPC advocacy, and they're often equivalent at the national level or at the local level. I gave you the official definition of IHPC advocacy, but this is what we are actually doing. We are sharing the vision of a world free from health-related suffering in the public square. As I said, practitioners and families who've received palliative care know its benefits, but policymakers often don't, and the public don't, and the media don't. So we're sharing that vision beyond the bedside. We're identifying and cultivating common ground with policymakers, with public servants. We're finding out what their agenda is and asking how we can help advance it, and asking them to help advance our agenda. We're connecting decision makers and influencers with service recipients and providers so they can come and see how important the work is. It's not just a theoretical possibility or something in a PDF. We're trying to connect them through language and through inviting them to see the services. We're also asking our membership and our partners to participate in governance by sharing evidence, which we will teach you about, and their stories, because it's stories that touch the heart. Our advocacy plea, this is what we ask our decision makers to do, is to please say the words, to put them on the record, in the documents, to include palliative care in all the agreed language of all the UN resolutions and government reports where they're so often forgotten and left out. And then to translate these, of course, into all the UN languages. We ask our decision makers when they go to the UN meetings and report on their progress towards multilateral commitments, such as, for instance, COVID or any other global public health issues, we want them to say the words palliative care at the UN meetings, to give it airtime so that people get used to hearing it. Because otherwise, when that word is just in silence, it doesn't become part of the public discourse. So our advocacy makes it part of the discourse of global health. The how is the stories plus the evidence. It's important in your advocacy to get personal, because the personal is universal. Doesn't matter if you're in a tiny village in Malawi, that often that last journey or the journey of illness without support can be valid in any country of any income level in the world. So the personal is always universal, and we try to share personal stories as well as evidence, but never one without the other. And we will have a module on evidence in the course. The where is everywhere. I had a very useful meeting in the ladies' room, putting on lipstick when I used to do that at the Commission on Narcotic Drugs. when I met the head of the European Union delegation, and we discussed a presentation I had just made in front of the mirror. And in one-on-one meetings with decision makers such as that, in multilateral meetings as an accredited non-governmental organization or non-state actor. So we do that when we actually present our official statements, when we have airtime as a non-governmental organization at the UN meeting. You can do it at smaller intergroup meetings in your country with other civil society organizations, with a faith group, for instance, with a trade union, with a women's group, with a disability group meeting. You, of course, can use traditional and social media. You need to cultivate your press contacts. And we put faith communities very upfront because that's often where the people are in many countries. Faith leaders have a lot of authority, and when we can get them on side for palliative care, that's very helpful in getting the word out. Insurance companies, academic institutions, of course, because they're the ones who teach, they need to include palliative care in the curriculum. So basically, the sky and your imagination are the limit. You can think about where you can do advocacy, everywhere and at all times. The when, at every opportunity, but specifically when we're preparing for meetings, conferences, or congresses, we register an IHPC delegation to meetings we're invited to, for instance, the World Health Assembly. We review the agenda for the meeting. We prepare statements on various agenda items. And then, this is still all before the meeting, we contact the government representatives, tell them what we would like them to say, to include in their statements, and ask them to please reflect our requests in their national statements. And then during the meeting, we participate in the meeting, whether it's virtual or live. We monitor it, and we report on social media throughout the meeting. I mostly tend to tweet through a meeting and report on how it's going. We organize side events. This photograph was taken at a side event we held on palliative care at the World Health Assembly that was very well attended. This gives us a chance, often an hour and a half, to explain what palliative care is, to give that evidence and stories, whereas usually we only get 2 to 3 minutes to present our case. Side events give us a chance to get into a lot more detail and to take questions. And then we schedule bilaterals, so maybe with another member state that we want to influence, or one that we particularly need to get on side for a certain agenda item, with secretariat staff and other NGOs. And then, of course, afterwards we follow up with asking people who have made commitments to implement those commitments. We ask how we can help them do that. We offer our assistance in developing policies or regulations, and we try to follow up with next steps. So some desired advocacy outcomes are effective collaborations, because we didn't have those before we did the advocacy often. So those effective collaborations between affected populations, those ones that don't have services, and with decision makers who have the power to develop budgets and services. We would like them to collaborate with us to develop training curricula and policies. So that kind of collaboration would be an important outcome. Funded palliative care budgets is an important outcome. Equity-based health system strengthening, which is not one that's normally associated with palliative care, but the evidence now shows that palliative care integration can help strengthen systems. And national monitoring and evaluation capacity. We can have great policies, we can even have funded budgets, but if we can't monitor and evaluate how those are being implemented, whether they're reaching the people they're supposed to reach, whether the quality of the services is what's supposed to be, then we're not going to make much progress. So these are all advocacy outcomes that we strive for. Some important examples of global wins, unprecedented wins since 2014, are the unanimous World Health Assembly resolution on palliative care. That's resolution 6719. At the 2014 World Health Assembly, this was the palliative care resolution which member states committed to in integrating palliative care into primary healthcare systems and to ensuring access to palliative care medicines. So that's where all health ministers of all your governments signed on to this resolution. And it's been slow going getting them to implement it, but that's the focus of a lot of our advocacy. It was a big win, though. Likewise, in 2016, the UN UNGAS, that's called UN General Assembly Special Session on the World Drug Problem, the outcome document from that session had an entire chapter on improving access to controlled medicines, with 7 operational paragraphs to member states and health departments and drug policy organizations and what are called competent authorities in your countries, how they can make sure that essential palliative care medicines get to the patients who need it. This was absolutely unprecedented in the UN drug control system, which usually just includes 1 or 2 lines or maybe a sentence on the need to improve access to controlled medicines, but it's just lip service. This is real operational paragraphs. In 2018, we made sure through our advocacy that palliative care was added to the Astana Declaration on Primary Health Care, which updated the Alma Ata Declaration on Primary Health Care from 1978. And I'm going to go into all these wins in our first module of the course beginning in October. Similarly, in 2019, palliative care was added to the Political Declaration on Universal Health Coverage, which was approved by the UN General Assembly. The original document and draft of that Universal Health Coverage Declaration did not include palliative care, just like Astana. So with our advocacy, we made sure it was included. And then in 2020 and 2021, we had 2 roundtables with Dr. Tedros Ghebreyesus, the Director General of the World Health Organization, to basically persuade him, teach him to include palliative care in all the operational work and technical work of the World Health Organization, rather than just confine it to 1 or 2 departments. And we had civil society organizations and palliative care associations from around the world representing their work to Dr. Tedros in these 2 very important roundtables, which lasted 1.5 hours to 2 hours each, as well as including palliative care in World Health Assembly Resolution 73-1, which was about COVID response. Again, the original draft of that resolution on COVID response for the World Health Assembly did not include palliative care, and through our advocacy, we were able to ensure its inclusion. So all member states, theoretically at least, and through their approval of this on-the-record document, have said that palliative care needs to be included in their pandemic response and preparedness strategies. So the next slide is an example of an intervention that I gave at the Regional Committee meeting for Europe in 2018 on access to palliative care medicines, which was one of the agenda items was an access to medicines generally agenda item. And I wanted to make sure that the member states present considered the importance of making sure that essential palliative care medicines were included in any technical work that was done in country. So we were not given a chance to rehearse our statement. We had prepared the statement, thank goodness, but we just went in cold to the recording. Ideally, we rehearse before recording these kinds of statements, but it gives you a sense of how short they often have to be, between 90 seconds and 3 minutes, and how you have to cover all the bases you can in a statement addressing that agenda item without rushing. This is our oral statement on the roadmap on access to medicines and vaccines. Your RC 68 Information Document 8. IHPC thanks the Secretariat for including controlled medicines in the Strategic Activities section of the roadmap and wishes to offer our support and that of the European Association for Palliative Care in helping to train providers, particularly primary healthcare doctors, nurses, and pharmacists, to prescribe and dispense controlled medicines for the treatment of pain and palliative care. This is a priority human rights obligation recognized by the Council of Europe and the topic of Chapter 2 of the outcome document of the 2016 UNGAS on the World Drug Problem. Rapidly aging populations, the rise of non-communicable and communicable diseases in the Euro region demand a properly trained workforce and balanced drug control systems for the rational use of controlled medicines. IHPC is also working with our medicines focal point at headquarters to ensure operationalization of this normative priority at the global level. I thank you. The course outline for the 8 modules, that are coming up is the following. The first one will be very similar to the basic course that's been available to our members for the last couple of years. It will go over the global and regional advocacy framework and the institutional landscape and the basic laws that govern our advocacy at the international level. The second will deal with drug policy, as it's called, which is a cornerstone of advocacy for essential palliative care medicines, which are controlled under the 3 international drug conventions. 3 will be the evidence base, because IHPC has a data platform which helps you get evidence about your particular country. And there are other indices, such as the Lyon Index on the place of death. And we'll present the evidence base for you so that we can work on number 4, which is to teach you to do needs assessments for your country, because you have to have a good needs assessment to be able to do evidence-based advocacy for your country. And then 5, we'll talk about governance frameworks, the national and regional palliative care advocacy and strategic partnerships with other civil society organizations, and then how we build relationships with member states so that we are actually talking about the where the rubber meets the road, so to speak, with the advocacy and how we do it. And then a case study, we're going to pick one of the agendas for a UN entity conference, and then pick out the relevant topics for advocacy for palliative care in that agenda, and then talk about how we develop an appropriate strategy and statements addressing those advocacy, those agenda items, and how we can bring those to our policymakers in one particular case study. 7 would be communications and presentation techniques for effective advocacy, and then 8, leadership skills. And this list may vary depending on the need and demand. So we expect our students to participate by telling us what you need and whether this particular list that we've outlined is going to meet your needs. The modality will be an online platform, Google Classroom. You'll have lectures like this for a maximum of 40 minutes with reading lists, assignments, and ancillary videos by other experts that'll be posted on that platform. Those of you who want to have a certificate will need to complete each assignment and a very short final project that we'll work on together. Or, of course, you can just audit it on your own time. And you can do the course on your own time. But if you want to do a certificate, you have to complete some of the requirements. And there will be no charge for IHPC members for this course. So just to end with, health is a political choice, Dr. Tedros' favorite thing that he says over and over again, because it is. It's not just something that politicians and decision makers wake up one morning and say that they're going to do this. We have to persuade them through advocacy to make that political choice. We stoke those fires through our work, and we're asking you to help us do that, to join IHPC, to take the course, and build this global social movement that our membership has asked us to do. So thank you for being a change agent, for considering it. You can go to our website, to hospicecare.com/join IHPC. It's on the front page of the website, and click and join as an individual or an institution. These are some selected references I used just to prepare this presentation, which you are welcome to refer to yourself. And then, of course, I can't end without acknowledging the help of Ms. Liliana de Lima, our Executive Director, Dr. Tanya Pastrana, who is our research advisor at the University of Aachen, and then our board, staff, members, partners, patients, families, and of course you. So